So I want to move on next to our next speaker. I'm very happy to introduce Dr. Daniel Pratt, who is in the hepatology group here at MGH. He's the director of the Autoimmune and Cholestatic Liver Center, and I have to say, a very active participant in our regular liver pathology conferences, which I think are tremendously valuable, both for us as pathologists and also for our clinical colleagues. And so I think I can't think of anyone better really to talk about this topic, which is kind of liver biopsy from the hepatologist perspective.
Thank you, John. Oh, it's a pleasure to be here. I always enjoy speaking to this audience in particular. And as John made mention, I feel very blessed to have the support of our pathology group because quite frankly, we could not function as hepatologists without the input that we get from our pathologists. So that's true right at the front. What I always like to start with is talking a little bit about the parable of the blind men and the elephant. And in this case, the elephant is actually the liver. And as opposed to being blind men assessing the liver, it's actually all of the different physicians involved in the care of these liver patients that are considering the liver. And it's really important to keep in mind that we all have a very different perspective as to what's happening with the liver based on our own particular view. And so, for instance, the endoscopist, the interventional endoscopist, I see a great many patients with primary sclerosing cholangitis. So the interventional endoscopists are an essential part of the care of those patients. And what I'll sometimes hear from them is, my gosh, these bile ducts look absolutely terrible. And they do, but the fact that the bile ducts look terrible isn't always a sign that the liver has failed. But that's one bit of information that's important. We'll hear from the surgeons if they have, say, taking out a gallbladder in a liver patient, excuse me, that we'll hear the comment that this is the worst liver I've ever seen. And again, helpful information, but it needs to be kept in the context of the care of the patient. We'll have the radiologist who will comment on cross-sectional imaging that, well, this liver looks cirrhotic to me. That can often start a whole cascade of angst and evaluation, because often that occurs in patients who are not known previously to have had chronic underlying liver disease. And frankly, they're not always 100% accurate. And then finally, my pathology colleagues who are essential, and I put in as the quote here is simply the differential is VAD. And I want to emphasize that what we look for as hepatologists is the mantra, clinical correlation, clinical correlation. The job of the hepatologist or the gastroenterologist is really to take all of the information provided to us by our colleagues and try to put that together in a meaningful way. That we should never have the expectation that any of our colleagues have the pressure on them to give us the answer necessarily, although we'd kind of be happy to have that happen. But really, it's a team approach. We're taking together all of this data and putting it together to try to care for the patient. So let's start, and I'll take you into the mind of the clinician who's ordering the liver biopsy. And so I say, why do we do it? And more specifically, well, what do we want the pathologist to tell us? And of course, we'd love to have an absolute diagnosis, but we don't have that expectation. We'll settle for a differential. We'll settle for some direction that we can then apply additional testing to try to reach an answer. We'll make a decision about perhaps a treatment course based on that. But it's not always, you should not feel the pressure of saying, I need to come up with a diagnosis on every single liver biopsy. We might be looking to you to gauge the severity of the liver disease for us. So we need to know, is this a patient who we need to initiate a therapy for? We may be calling on you to help us monitor response to therapy. And this is where having the serial biopsies and knowing that we have access to older specimens for comparison is so important. And our group is always wonderful about digging out those older specimens so we can see over the course of time what may be happening for that individual patient. And there are times that we're actually quite surprised by things that can change over time as well. So going back and looking at those older biopsies in addition to the new specimens is often absolutely essential. What should the pathologist reasonably expect the clinician will provide? And this is all perfectly reasonable, that we hope you'll receive all of the relevant clinical information. I think this has become easier in the Epic era, but I feel like our poor pathologists are spent a great deal of time trying to gather that information. And then secondly, you should know what actually our question is. So when we do a liver biopsy, and this is an important teaching point for our fellows, any test that we do, you should have a question. So you shouldn't just be doing a biopsy and handing it off and saying, well, tell me what you see. No, I mean, we should have a question up front that we're asking you to answer. And abnormal LFTs is the only bit of information you might get, is neither relevant clinical information, nor is it a question, and that's just not fair. You know, we try to give that information that's needed. Often that gets filtered through the interventional radiologists who do our biopsies here at MGH. So I feel like sometimes the information in that path might be a bit lost, or at least diluted. So this is why, and John made mention of this, what is the best way to care for these patients? And when they're having liver biopsies, and the answer is this is the ideal way to communicate. And this was certainly something that we looked forward to, where many of the hepatologists and pathologists would be able to gather around the multi-headed scope, present the case, talk about the biopsy, talk about management. I mean, it was really an absolutely wonderful way to manage these patients. Sadly, COVID has derailed that sort of interactions, although I keep hoping we will move back to it at some point in the near future. But since COVID, we have used Microsoft Teams here at MGH to have these sorts of conferences. And as John says, they continue to be very meaningful. I try to attend every single week. There's always something to be learned, both the pathologists teaching the clinicians and the clinicians also providing information and teaching to the pathologists. So it really is a wonderful interaction. Hopefully even more meaningful when we can get back to the in-person one. So what are the things that are changing? What are the things that you should be aware of in the world of liver disease? And there clearly is a diminishing role of the liver biopsy for certain diseases, particularly primary biliary cholangitis. Why is that? Well, there has been changes in our societal guidelines as to what is required to make the diagnosis of primary biliary cholangitis. And so both the AASLD, EASL, and ACG, so North American and European guidelines, say that diagnosis requires just 2 of 3 criteria. The first is a cholestatic pattern of liver enzymes, which is usually how these patients are coming to our attention. And then we check an antimitochondrial antibody as part of their evaluation. And the AMA is found in greater than 95% of patients with PBC, certainly over 90%. The third criteria is consistent liver histology. But based on the first 2, we can diagnose PBC and treat it without a liver biopsy in well over 90% of patients. So as a result, the role of histology has dropped quite dramatically. Now, I'm not sure that's necessarily a good thing, but that's the reality of it. I am actually an advocate for doing the biopsy because there are things to be found there. And I'm always of the mind that if you didn't do a baseline biopsy, you're never going to have something to be able to go back and compare to if you're managing a challenging patient. So with that in mind, why would we as clinicians order a biopsy in a PBC patient? Well, there still are diagnostic indications. If you have a patient with cholestatic LFTs and you're convinced this patient has PBC, but lo and behold, their AMA is negative, well, now to get that second criteria, the biopsy becomes essential. We see patients referred to us typically from the rheumatologist who are found to have a positive AMA, but normal LFTs. All right, so what do we do with this? Well, there's a chance that a small percentage of these will have histology consistent with early stage PBC. And we also know that 1 out of 6 of these patients will actually develop clinical PBC over the next 5 years based on old studies. So it's an important group. What I tend to do with these patients is try to convince them just to wait until their LFTs become abnormal before we start talking about an invasive biopsy. But you may run into a circumstance where someone has asked for a biopsy and a positive AMA, but with normal LFTs. The third is to assess for histologic features supportive of a diagnosis of an overlap syndrome. And I'm going to come back to this because I think this is a meaningful enough area that we should talk some more about. So we'll come back to that in a few minutes. The biopsy at baseline in PBC can have prognostic significance that we'll talk about in a moment. And there's also the chance that it can help, or actually should help, guide our therapy. So there is still a role here. So how is it a predictive prognostic value? And this is a paper published back in 2008 of what was called the Paris 1 criteria. So the goal of this study was to look for predictive factors for death or transplantation in patients who are on ursotherapy. So how do we tell if the ursotherapy is working? And it turns out that if there was an absence of a biochemical response at 1 year of ursotherapy, that was the strongest predictor of progression of disease. But a couple of these were pathology related. If you had a baseline stage 3 to 4 histology, that was a very bad predictive sign. And another one to keep in mind is that patients who have moderate to severe interface hepatitis also did more poorly. So, well, how does this change things? Well, these are groups of patients where we as the clinicians should be actually much more aggressive in our management of these patients. And things are changing in terms of therapies for PBC that I'd like to share with you in just a moment and let you see how this could make a difference. But a big question, and I'm sure you're all aware of this, is that if our one goal is to look for advanced hepatic fibrosis on a biopsy, or that's what we're looking for in a patient, do we really need a biopsy? What are the other things that we can do? And so we know there are very effective non-invasive testing serum markers that we can look for. And there's something called the fibrosis 4 index, which is a very simple formula that I put out for you here, and use some simple blood tests and age, and we can use this. And if we have a FIB4 score that's greater than or equal to 1.3, or if you're over the age of 65, if it's greater than or equal to 2, this is a sign of advanced fibrosis. Of note, this particular test does not perform well at the age extremes, which is why they have a slightly different value for the older patients. There's also, which is a test which is gaining approval and gaining use in the liver world, something called the Enhanced Liver Fibrosis, or ELF score. This is being used quite extensively in NASH, and we're starting to apply it more in cholestatic liver diseases. And what this is a panel of biomarkers consisting of just 3 components: type 3 procollagen peptide, hyaluronic acid, and tissue inhibitor metalloproteinase 1. So using those 3 things, you can generate this ELF score, and that has turned out to function quite well as a non-invasive marker of liver fibrosis. But then the one which has gained the most approval in the liver community, and something that most big liver practices have in their office space, is something called transient elastography, or FibroScan. And what this is it's a rapid, non-invasive, reproducible measure of liver stiffness. So using an elastic shear wave, we can actually measure the stiffness of the liver. And what we get is a measurement in kilopascals of the velocity of the wave, which then relates directly to tissue stiffness. So in general, the higher the kPa score, the greater the stiffness in the liver. And this has been validated in a number of different diseases now. But what's important to know is stiffness, actually, the stiffness threshold values vary by disease type. So that's why it had to be validated in every different type of disease. But this has become a very routine part of our management of liver patients in the clinic, and as a way to look for disease progression, a way to look at baseline liver fibrosis. All right, so with that in mind, let's talk a little bit about, again, PBC and advanced fibrosis. I've shown you the Paris-1 data showing that histologic stage 3 to 4 on a biopsy was a bad prognostic sign. Those are a group of patients we want to keep an eye on. That was validated in a second study of 1,828 patients from a large cohort of PBC patients who had baseline liver biopsies, and they showed exactly what the Paris-1 study showed, which was that advanced histologic fibrosis was an independent predictor of survival. So then the big question was, could we obtain the same sort of information non-invasively? And so this study looked at transient elastography and MR elastography, another way to measure that stiffness. I'll make mention that MR elastography is much more expensive than the transient elastography, so it's done much less frequently. But what we found in this large group of patients was there were cutoffs that were predictors of hepatic decompensation. So the point being, this might be a way to avoid that baseline biopsy for the specific indication of fibrosis. There yet are other things, of course, to be seen on the biopsy. So with all that in mind, how does that fit into our treatment of these patients? Well, first-line therapy in every patient with PBC should be on ursodeoxycholic acid. That it's been the only FDA-approved therapy for 25 plus years up until 2016. And what I can tell my patients when they come to clinic and we start them on therapy is that they have about a 60% chance that they will respond to urso monotherapy. That means they'll have a biochemical response, which we know correlates with a positive outcome. So that leaves 40% of patients who potentially need additional therapies. So what are those additional therapies we could offer? And the second line therapies that was FDA approved back in 2016 was a steroidal FXR agonist called a beta-cholic acid. And what this is a drug that was modified from quinodeoxycholic acid, but actually has 100-fold greater affinity for the FXR receptor. It functions by decreasing bile production, increasing bile secretion and flow. It has some anti-inflammatory and anti-fibrotic effects, but sadly, pruritus was a common and treatment-limiting side effect. So this was a drug that was great to have for patients who needed it, but the reality was the side effects often minimized the ability to use it. That leads us to today, which is where we now have a second exciting class of potential drugs to use. And these are the PPAR agonists. And PPAR agonists are agonists of the peroxisome proliferator activator receptor family of nuclear receptors. And this is fascinating when you look at these are the list of the various drugs that are available. There are 3 different PPAR receptors. And if you notice, these drugs have different permutations of which of the receptors they're activating. So the reality is we know that these drugs work through various pathways and clearly have anti-cholestatic properties and clearly have some anti-inflammatory properties. But what's amazing is that despite this variation in the receptors being activated, they all seem to have benefit. So fenofibrate and bezafibrate are fibric acid derivatives, and they've been, bezafibrate is FDA approved in Canada, well, not FDA approved, but regulatory agency approved in Canada and Europe. Fenofibrate is available in the US, but only as an off-label drug because its approval is for hypercholesterolemia. And it's a drug that I've used extensively. But 2 of these drugs, elafibranor and seladelpar, both had their phase 3 studies published in the New England Journal of Medicine earlier this year, and both are coming up in front of the FDA in the next 3 months. So I expect both of these drugs will actually gain FDA approval by the end of this year. And so we're going to have additional agents available to us for the treatment of those 40% of PBC patients who are not responding to urso monotherapy. So how does this all then fit into practice? Well, this is the role of potentially of the pathologist. And a message I try to really make clear as I give talks on this is that you need to stage your patients before treatment. You can't just get the cholestatic LFTs and the positive AMA and you're off and running. No, you need to stage your patients, and that can be with a biopsy or with some form of non-invasive imaging with either transient elastography or MR elastography. And if you have advanced fibrosis on any of those measures with numbers I've noted here, what that changes is that if you do have advanced fibrosis, we should be moving to additional therapies at 6 months, not waiting a year, which is what we typically have done. No, we should be moving more aggressively in those patients. And the expectation is that second line therapy, once they're available, will likely become elafibranor and seladelpar just because they're better tolerated than the OCA, the FXR receptor agonist. And in addition, as opposed to provoking pruritus, they actually are effective in treating pruritus. So you can imagine for this class of patients and for hepatologists treating this class of patients, a drug that actually treats pruritus is much more appealing than a drug which might provoke pruritus. So that's the role still potentially of the pathologist. So your staging of the biopsies of these PBC patients is actually of critical importance to us. So what are to summarize our PBC stuff, the questions the clinician would like to have answered: is the histology consistent with PBC? And where are those cases that we're looking for that? Patients with cholestatic LFTs and a negative AMA, or perhaps patients with normal LFTs and a positive AMA. Then the second part is, what is the stage of disease? And we're now coming back to that point of the interface hepatitis, which is something, of course, the MRE and the transient elastography can't tell us. And so that's where the biopsy, to me, still has some benefit. I want to know how inflammatory this PBC is. And a big part of that question is there overlap with autoimmune hepatitis? So let me emphasize that it should not be the expectation of any GI or hepatologist that the pathologists make the call that this is overlap syndrome. In fact, I would encourage you never to put in your report definitively this is consistent with overlap, because the reality is that diagnosis is not made strictly on histology. It's a combination of things, and this is the Harris criteria for defining overlap syndrome in PBC and AIH, which is what we as hepatologists apply, and realize that well-trained hepatologists are going to know this, but GI guys in the community are going to take what you say as gospel. So if you tell a practicing GI guy that this is overlap syndrome, those patients will end up on prednisone. They will end up on azathioprine. And those patients often come back, might come for a second opinion, and we're left trying to then unravel that and say, in fact, no, this was all PBC to begin with. So realize if you're concerned about it, it can be mentioned in the report to consider it, but you should never go so far as to say this is overlap. So what are the things we look for? Well, you have to have at least two of the following, and then you have to have the alk phos being elevated and GGT being elevated, positive AMA and florid bile duct lesions, or you have to have, and this is key, an ALT greater than 5 times the upper limit of normal. So all that patients referred as overlap, and you'll look at their baseline ALT and it was 80 or 90. And you say, well, this wasn't overlap. This couldn't be overlap based on this. You have to have IgG levels greater than 2 times the upper limit of normal, or SMA positivity. And finally, that biopsy, which might prompt the pathologist to think, oh, could this be overlap? But we need to put the other pieces together. So I encourage you to keep that in mind as you're reading these biopsies. So how about the role of the liver biopsy in other diseases? So we'll go through these quickly, as I know time is getting short, but let's talk hepatitis B. So when we see a patient with hepatitis B, the clinician is thinking, what stage of disease are they? And are they immunotolerant? Well, those patients do not require therapy. Are they immunoactive? That would be a group of patients who would. And the difference here is they're all e-antigen positive, e-antibody negative, but typically the immunoactive patients have an increased ALT, whereas the immunotolerant don't. Well, then the next question is, in the group that we're trying to differentiate, is between the inactive carrier patients who have seroconverted with loss of e-antigen and gaining e-antibody with normal LFTs, very low DNA levels, really at least less than 2,000, if not even less than 200, versus the E antigen negative hepatitis patients who have higher level of DNAs, but may or may not have increased ALT. So because this group does not require treatment, this group does. Well, guess what? There is a very important role for the pathologist in differentiating between these patients. So if we look at our big question, if someone is E antigen positive, E antibody negative, is are they immunotolerant and immunoactive? It's easy if the ALT is elevated. If the ALT is normal and the DNA is elevated, but the age is getting on, because we know the older you are, the more likely you are to be immunoactive, that may be a group of patients we ask you to interpret a liver biopsy for. We're looking for inflammation in particular. And just quickly on the other side, if they're E antigen negative and E antibody positive, and the ALT is normal, well, now the DNA level becomes very important. And there can be this group of patients who hover at a DNA level of around 2,000, and we're not sure which of the two they are. Because if they're active in this E antigen negative hepatitis group, we're going to want to treat them. And so again, the biopsy becomes very important. So to briefly show you a case, this was a 36-year-old woman who had Hep B through vertical transmission. So she's been infected for nearly 36 years. And her surface antigen is positive, LFTs are normal, E antigen negative. So she is by definition either an inactive carrier or an E antigen negative hepatitis. And here's where that DNA doesn't help us. So this is 20,000 easy. It's a patient who's E antigen negative hepatitis. If it's undetectable, easy, that's an inactive patient. But what about this gray zone? And so the biopsy, here was the biopsy showed, and the quote was, there is no evidence of portal or lobular-based necroinflammatory activity. Immunohistochemistry for surface antigen is positive and core antigen negative. Trichrome stain shows no fibrosis. So what was our takeaway as a hepatologist? There was insufficient inflammation to justify treatment. So we're categorizing this patient as an inactive carrier. And there was insufficient fibrosis to justify screening for HCC. So the more advanced the fibrosis in a 36-year-old woman, she would need to have cirrhosis or very advanced fibrosis to justify HCC screening, because the guidelines suggest you only initiate HCC screening in non-cirrhotic Hep B patients once they've reached the age of 50. So questions for Hep B: is there sufficient inflammation to warrant initiation of HBV therapy? And we're looking for that interface in lobular hepatitis. And what is the stage of fibrosis to think about HCC screening? Immunostains are not helpful in the clinical management of these patients. So I always love seeing them. They're cool to look at, but the reality is they're not useful to us. Quickly, autoimmune hepatitis. I know you've heard a little bit about it. You play an important role because the histology in these various scoring systems is a critical piece. And if it's compatible with autoimmune hepatitis in this one, you get a point, whereas if it's typical, presumably the sheets of plasma cells, you get 2 points. So knowing what you guys have to say is really important. And really a biopsy it has to be done to diagnose this. And just to show you a case where it can be an issue, particularly for guys practicing in the community, this was a 58-year-old woman, had LFTs checked as part of an annual exam. She had elevated transaminases quite prominently, but otherwise everything was negative. The ANA is negative, SMA is negative, SPEP was normal. And the biopsy showed a panlobular hepatitis with multifocal necrosis. And you can see 75% of the parenchyma was involved in necrosis and collapse. There was a mixed inflammatory infiltrate. And the quote from the PATH report was that given the negative hepatitis serologies and autoantibodies, the etiology of the panlobular hepatitis is unclear. Well, what this served to do was to paralyze the clinician who was getting the report, and they didn't know what to do with it. So this is the case where we are always okay with hearing from you. These features are consistent with virus, autoimmune, drug. All right, that comes back to us. We need to determine the right treatment. This patient was put on therapy for autoimmune hepatitis and responded beautifully because drug had been ruled out and virus had been ruled out. So realize that then it's okay to give us that differential and kick it back to us. So the things we're interested in with autoimmune hepatitis is, are there findings diagnostic of or consistent with autoimmune hepatitis? And we always like to say, beware of fibrosis staging on the diagnostic biopsy. I always like to show this biopsy from my mentor at Tufts, Marshall Kaplan, who is a world's expert in autoimmune cholestatic disease. And this was a case which was read as cirrhosis in an autoimmune HEP patient. But of course, with therapy, we could say, oh, we've cured their cirrhosis, when in fact, this was all likely just parenchymal collapse. And so we can feel good about curing cirrhosis, but I'm not quite sure we actually did. So it's always important, just keep that caveat in mind, that don't overread it. And so I'm not going to spend any time on this. This is the algorithm I use to treat these patients. But the key thing for you to understand is, in my practice, a follow-up liver biopsy after 2 years of normal LFTs is essential, because I'm looking for a histologic remission. We're looking for a biopsy that shows a complete resolution of those features of the disease that would suggest ongoing activity: interface hepatitis, a dead hepatocyte, globular inflammation. If we're seeing these things, then we can be rest assured that if we stop treatment, the patient's going to flare. I don't know when they're going to flare, but they will flare. If we can knock it back to the point that you're all, as pathologists, convinced we've eliminated all of those features, that's a patient who deserves to at least come off of treatment for at least, and they're monitored very carefully. So what we're wanting you to ask here is that, has there been a complete resolution of inflammation and a follow-up autoimmune hepatitis? Have we eliminated those features that we all know are hallmarks of the disease? And finally, you heard a lot on fatty liver, so I'm not going to take a great deal of time here, although to say that you guys are actually very important here as well. We know from diagnostic features, you've heard this, most patients, we think about it, them being transaminase elevations. Alk phos can be up in a third of patients. A large number have ferritin, which can be a marker of inflammation and not necessarily a marker of iron overload. So that's not surprising that's high. They can have a positive ANA, so you're sort of getting the flavor that you heard about earlier. It can be hard to judge. And so radiology, sure, our imaging is actually quite sensitive for a heterogeneous liver, but we don't always know that that's fat. And most importantly, they can't differentiate between steatosis and steatohepatitis. And so what we want to hear from the pathologist when we're doing these biopsies is often, is there another explanation for these liver test abnormalities? And the two biggies often being autoimmune hepatitis and hemochromatosis or iron overload. Is there steatohepatitis present that might push us to treat? Is there fibrosis present that might push us to treat? And just what is the urgency? And I'll show you this briefly. I won't go through it in any detail, but you may know that we have the first drug FDA approved for the treatment of fatty liver disease. And this was the phase 3 trial published in the New England Journal just earlier this year, which looked at this thyroid hormone receptor beta selective agonist. And all they showed with this very quickly was that, boy, you could have a higher percentage of NASH resolution in the treated patients, and you have fibrosis and greater likelihood of fibrosis improvement than greater than or equal to 1 stage with no worsening of NAFL activity. So this is something now that we as hepatologists are having to think, is this a drug that we need to be applying in our patients? So to conclude, excellent patient care truly depends on a clear communication between the clinician and the pathologist. You guys are absolutely essential to the care of these patients. And that depending on the particular liver disease, there are actually very specific questions the clinician wants answered in order to optimize that management. So I'll finish there. Thanks for your attention.